Good afternoon, everybody. People still joining to take their seats, but I think in the interest of time, we'll get started. You're very welcome to this session, Mastering the Future of PCI with DCB. My name is Robert Byrne, interventional cardiologist in Dublin, Ireland. I'm anchoring the session and delighted to have Bruno Scheller, who needs no introduction in this room, as the spokesperson. He will moderate any questions you have, so please, if you have questions, you can ask them through the app, and we will address them. Very pleased to be joined by discussants, Raban Jaeger, Maximilian Opolski, Simon Eccles-Hall, and we look forward to their insights very much. Now, I know the room is full here. There is overflow transmission to a second room. So if you're outside and you can hear this outside, I think they're putting up a sign to tell you which room to go to watch the stream of this, or you can also watch the stream at the B. Brown booth. So I'll start with the learning objectives for the session. And what we'd like today is to look at some of the latest insights into the available data for DCB usage, particularly focusing on de novo disease. And in my presentation, I'll include some of the studies that were presented at EuroPCR this year. Focus then on practical experiences with DCB across the spectrum of indications, large vessels, bifurcations, and CTO, and get an understanding of how to use the hybrid approach, especially for challenging lesions, aiming to improve patient outcomes. So against that background, it's my job to provide the starter course. The guys here, the expert users and adopters, will provide the main course and the dessert. But I'm going to start by giving an overview, PCI 2.0, drug-coated balloon angioplasty. These are the topics I plan to discuss over the next 8 minutes. Touch briefly on the developments in the United States. I think it's important. One slide then just to remind us of the favorable efficacy-safety balance in in-stent restenosis. Re-emphasize the key message of back to basics, angioplasty with DCB. Then look at some of the newer directions in de novo disease, and I'll start by highlighting 3 studies. I'll finish by highlighting 3 studies that were presented at PCR this year. So I think last year when we met, we issued a statement to the PCR community who said it's remarkable that in 2023 there are no devices approved for coronary use in the United States, although pre-market approval trials are ongoing, and this situation may soon change. And you'll be aware that the situation has changed, and at TCT last year, it's worth mentioning that the primary results of the AGENT IDE coronary trial were presented. You could say it was a straightforward question, maybe an obvious answer if you do balloon angioplasty with DCB compared to balloon angioplasty with an uncoated balloon in in-stent restenosis, you'll get better outcomes with the drug-coated balloon angioplasty, something I think we know for many years. But this was necessary for approval in the United States, and drug-coated balloon for coronary use, first device approved by the FDA the 1st of March 2024. And I think this gives important momentum to the field, and we look forward to further devices receiving approval there over the coming years. As regards in-stent restenosis, we know the situation very well. There's a Class 1 recommendation in clinical practice guidelines for the use of drug-coated balloon angioplasty for in-stent restenosis. This is a summary analysis of the first 10 randomized trials comparing DCB with DES. You can see on the top right. There's a small efficacy gap, actually, compared with implanting another stent, a small anti-restenotic efficacy gap with drug-coated balloon angioplasty. But we think it's worth this small decrement for potentially improved safety down the line, and you can see the rates of death in MI tended to be lower with drug-coated balloon angioplasty compared with drug-eluting stent. And this is why, for many of us, drug-coated balloon angioplasty, I think, is the first option for in-stent restenosis, and it has a Class 1 recommendation in clinical practice guidelines. When we talk about drug-coated balloon angioplasty, I think we always emphasize in these meetings the importance of getting back to basics, the importance of remembering that drug-coated balloon angioplasty is merely a device for delivering local drug. The preparatory work needs to be done already by appropriate lesion preparation, appropriate lesion predilatation. We do not dilate the lesion with a drug-coated balloon. The second thing that we always emphasize is pay careful attention to how you handle the devices. Different devices handle on the table a little bit differently, and be careful, at least in our practice, not to touch the balloon before introducing into the body, and also to get the device speedily to the target lesion. We saw in the live case arena this morning an example of drug-coated balloon angioplasty, but I think they took a little bit long to get the device to the lesion, and we're worried if you take a long time that you lose some of the coating on the way. Proper lesion preparation, I think, begins with high-pressure balloon angioplasty and modified balloon angioplasty, either with scoring or cutting balloons. And we have randomized trial data to say that the performance of drug-coated balloons are better if you systematically use cutting scoring balloon angioplasty before drug-coated balloon. So looking then at new directions for drug-coated balloon angioplasty, we can appreciate that there is this renewed interest. We can see it here in the room today. We can see it in the people who are waiting outside, and we can all see it in the we can also see it in the number of scientific publications that continues to increase in the area of de novo disease. I mean, there are many indications to think about. I would say overall, we don't have strong guideline recommendations for DCB use in de novo disease at present. But the expectation is that that will change because, as I'll show you in the coming slides, there are a large number of large studies which will report data over the coming years. When we think about de novo disease, we think about small vessel and diffuse disease, high bleeding risk patients, acute coronary syndrome, bifurcation PCI, plaque sealing. But more and more, we think about all comers or more comers and using DCB across the board. Small vessel diffuse disease, I think, is the most compelling indication personally. We have data in high bleeding risk patients from the debut trial, but I'm not sure this is the best niche. I think we also are comfortable with short DAP now after drug-eluting stents. Acute coronary syndrome is an interesting area, but I think we're focusing more on the spectrum of all presenters rather than the niche of acute coronary syndrome, because we have good results with stents in acute coronary syndrome. And bifurcation is an area where we need more data. An interesting study reported recently using plaque sealing. This is NIR's result, one case from the debut LRP study, which you may have seen presented recently. A plaque sealing approach, NIR's at baseline in the middle panel, NIR's at follow-up after drug-coated balloon angioplasty on the right panel. And systematically, there was an improvement and reduction in lipid with the drug-coated balloon angioplasty approach for plaque sealing. Upcoming data, the reverse trial. These are the large trials that will report data over the coming years and may finally tip the dial in terms of clinical practice guidelines. Large trial, 1436 patients, enrollment well advanced. We look also for update with sirolimus-coated balloon angioplasty, in particular in the SCORE trial, also substantially progressed there, more than 1,100 patients out of 1,300 patients. The REC cage-free one trial, they presented data at PCR yesterday on antiplatelet therapy, but they also have data looking at drug-coated balloon angioplasty compared to drug-eluting stents. 2,270 patients, and they're expected to present at ESC 2024. And then Simon Eccleshall is running the Solution de novo trial, which is also substantially advanced. 3,300 patients. So these are the type of trials that will influence practice. And this and other ambitious trials will define the role of DCB in de novo disease going forward. Very quick to finish then, 3 studies that caught my eye so far at PCR. Simon presented the first 1,000 patients of the solution trial, looked at the baseline characteristics, saw about a 15 to 20% crossover to stenting with improvements over time. The second study is the abluminal DES Plus study. Just to mention, this is a hybrid drug-coated balloon and drug-eluting stent, a novel device which didn't show promise when compared with standard drug-eluting stent. And then the third one to finish on is what I showed you a moment ago, the cage-free 2 study, which is the first trial to specifically look at the duration of dual antiplatelet therapy in patients who are treated with drug-coated balloon angioplasty. And they looked at an abbreviated DAPT versus a standard DAPT strategy and saw generally positive results. So it's studies like these and the ones that are upcoming, I think, that will move the dial over the years to come. So thank you for your attention. So it's my pleasure now to call on Maximilian Opolski, who's going to talk about an interesting area of development. It's certainly one that we're gaining some local experience in Dublin, using DCB in CTO.
So thank you very much. May I have my slides?
And just a reminder, while Maximilian's slides are coming up, please, we're looking forward to your questions through the app, and Bruno will moderate them and put them to the panel.
Okay, so for the next 8 minutes, we're going to talk about the use of drug-coated balloons in CTO PCI. I want to highlight that it's quite an untapped territory, so we are not having much data about that, but it's actually coming, and I'm more convinced than ever we're going to hear about that more in the future. So here is the consistent CTO trial from UK, which is, I think, one of the best CTO trials performed ever. Difficult CTO, high JCTO score, the best operators ever, delivering a high success rate of 90%. Right, and people try to present this trial during CTO PCI meetings. Well, it's a good trial, right? We can open up difficult CTO, but there is a small caveat. Look at this stent length, it's almost 86 millimeter per patient. And actually, if you look at the rate of major adverse cardiac events at 2 follow-up, it's 12.5% in patients without diabetes, and it goes through the roof, 36% in patients with diabetes. Now, that's another quite fresh study which tells you that the predictors for MACE in CTO PCI are actually the presence of diabetes and the cumulative stent length. So the question which comes to my mind is that maybe we are barking up the wrong tree, and that is the stent tree. So may we have a good answer to that? Well, what's the rationale for the use of drug-coated balloons in CTO PCI? I think apart from the rationale used in all other coronary lesions, it's the safety issue, right? And it's already occluded. So in the worst case scenario, I know it sounds quite strange, we're gonna go to the status quo phenomenon, right? Number 2, we have readiness for collateral recruitment. That's kind of a safety net, right? So we are not starting from the patent coronary vessel. It's already closed. And we have these collaterals which may take over once something happens. Number 2, if you want to do a decent, good optimization of the vessel 1-to-1, which is endorsed nowadays, we might run with some dissections, which is sometimes quite good and favorable for a good long-term result. And dissection is part of the job in CTO PCI business. And the last thing, most important, the shorter the metallic stent, the better for your patients. And I showed the study which was referring to that. So it doesn't really look like that. It looks like walking through the park, right? And another incentive to use drug-coated balloons in CTO PCI is that you might induce positive vessel remodeling, which is quite often the case. Now, and it's particularly silent with paclitaxel-coated balloon. Now the question comes, which CTO vessels might grow at the long-term follow-up, right? So you don't really want to implant small diameter stents. And actually, we have data about that. And the independent predictors of vessel CTO distal target enlargement is the presence of the CTO in LAD, the moderate to severe calcium, and small distal lumen diameter. So the smaller your distal lumen diameter, the bigger the expansion of the vessel that follow up. And mind you, most of these CTO PCI lesions gonna expand, like 67% in a different study. So that's a case from our side. It's CTO of LAD. We recanalize that with small dissection plane, and we have this image in the middle, right? And we are losing the diagonal branch. So we said, well, instead of doing the risky business, try to rescue that and tidy up, maybe we should use drug-coated balloon. We don't want to risk this diagonal branch, which is not small. We use drug-coated balloon, and that's a 3 months follow-up. The diagonal branch comes back. And it's easy, right? You don't have to mess up with stents. So here's the protocol. Everyone knows we need a decent pre-dilatation. How can we use DCB in CTO PCI? Well, you can go for a hybrid approach, so you can implant a stent and use the DCB in the distal target, and it's actually tested in the randomized single-center clinical trial in Amsterdam. The PI is Paul Knappen, or you can go for the pure DCB approach. Now, what data do we have in the first case scenario? Well, there is just one study from China. They compared, it's all retrospective, by the way, 281 patients treated with drug-coated balloon against 310 with drug-eluting stents, and they found out that actually, although you finish up the procedure with slightly higher diameter stenosis, at the long-term follow-up, there is no difference whatsoever regarding the major adverse cardiac events. And if you look at the angiographic follow-up, actually you have negative late lumen loss in the patients treated with drug-coated balloons. So it's improved. While if you look at the coronary stents, it's going to be, of course, a positive late lumen loss. So it can just be worse. Now, what data do we have in the drug-coated balloon-only approach in CTO PCI? Well, we also have retrospective studies, and that's all of them quite fresh. That's a study from South Korea, 93 lesions with a clinical follow-up of 2 years and angiographic follow-up of 6 months. The late lumen loss was almost 0, and the binary restenosis rate was 15%. And clinical follow-up was quite favorable, in my opinion. The TVR was 13%. Now, if you look at the patient characteristics, 38% of these patients had diabetes. The most commonly treated CTO vessel was LAD, and the mean number of DCB diameter was 2.7, so they were not playing low. And the DCB length was 42 millimeters. Now, the procedure ended up with dissections in the vast majority of patients, but most of these dissections were below type C dissections, right? So if you want to have a good result, the result comparable to this study, you must run into, let's say, non-significant small dissections that don't really impede the coronary flow. That's another study from Japan just 1 year ago, 85 lesions, TLR after 29 months was 12% angiographic follow-up, negative late lumen loss. If you look at the patient characteristics, almost half of the patients diabetic, they used retrograde approach in 28, almost 30% of these lesions. And again, they even did rotablation in some of these patients, and the diameter of the drug-coated balloon was 2.8, the length quite high. So I think that, just to summarize, I think the best candidate for DCB, we don't have much data about that, currently is the patient where you aim and get intraplaque wiring. You have, maybe it might be the LAD, small distal target. You don't really want to implant small stents. Diffuse disease, it's going to grow. And you have to take the clinical parts into consideration. We are just currently running the CTO, the novo registry, to know more about that. We already have 250 patients, 42 active sites, and I'm sure we're going to get more data about that in the future. Thank you.
Maximilian, thanks very much, and I'm sure we'll have interesting issues to discuss on that at the end of the session. You can, at the end of the session, ask questions at the microphones in the room as well as on the app, and we can see some of the questions coming through already. So my pleasure then to hand over to Bruno Scheller, who's going to talk about DCB in multivessel and diffuse disease.
Yeah, thank you very much, ladies and gentlemen. It's also a great pleasure for me being here. Why are we talking about DCB for de novo? Because even with current generation drug-eluting stent, there are device-related events after the first year in the range of 2 to 3%. For example, here in this work from the Munich group. If we look at this data in more detail, you can see that this event rate is increased if you treat more than one lesion. And with a longer lesion length, there's a steady increase in those events. This means the more stents you implant, the longer stents you implant, the higher is your device-based event rate. So the concept of DCB only focuses on lesion preparation, as you know, and according to the result of the lesion preparation, there's the decision if you can use DCB for local drug delivery or if you should implant a drug-eluting stent. And this is an algorithm that allows you to reduce the total number and length of stents if you treat multivessel disease. This is not intended to replace stents, but to lower the number. And what do we gain? We gain vasomotion, not even in the treated segment. It's clear that the stent has no vasomotion anymore. But we see it also that in the distal segment, vasomotion is improved when using a DCB compared to a stent implantation. What we also gain is lumen. It's called late lumen enlargement. This is an effect you can see in about 2/3 of our lesions treated with paclitaxel-coated balloons. And you can see this unique shift in the MLD distribution from the left to the right, which is only has been seen with paclitaxel-coated balloons in this form. The old axiom of angioplasty was the more you gain, the more you lose. This means if you have a better lumen gain initially, you have to pay a price in terms of a higher date lumen loss. If you look here from the Transform 1 trial in the sequent please arm, you can see that with a higher dissection volume, there's a tendency for a decrease in late lumen loss. This means the more you do, the more you gain, and not the more you lose anymore. This is an example of a long diffused LAD pre-treatment with a semi-compliant balloon, and what you get here is a dissection and not a satisfying primary lumen gain here in this area, so this is not yet ready for DCB. We know from experience and from also this data that if you use coring balloons for lesion preparation, at least in non-calcified lesions, that you have a higher probability to avoid flow-limiting dissections, and you gain a better residual stenosis, and that's what we did here, using 4 times this coring balloon, the NSC alpha. This was the result, clearly improved compared to the semi-compliant balloons, but still dissection here, and this hazen is there. Again, scoring balloon in these areas, and that's what you can get with careful lesion preparation, despite the fact that it looked not good after semi-compliant balloons. This was clear then 2 paclitaxel-coated balloons, 2.5, 25, 3.0, 25, and this is the final result. If you have a stent approach, you would end up with full metal jacket here in this mid-LAD. This is an example from a patient after bypass surgery with occluded lemur, and he had this calcified lesion in the right, which was which was treated with multiple inflations, including high pressure and scoring balloons. Finally, then treated with IVL to correct the calcium. And this was the result of the lesion preparation. And what you can see here, we have created dissection in the proximal part. And in my opinion, osteal disease requires stenting. So here we had a hybrid approach with drug-eluting stent implantation, inclusive optimization in the proximal part, and DCB in the mid and distal part of this right. here, if you look at the OCT in the DCB treated area, it doesn't look very nice. We have dissections, but we have a good flow and no flow limiting dissections, so you can accept it as a result after DCB treatment. This is the result 4 months later in the same patients, a stable situation. In calcified lesions, we do not see that often this effect of lumen enlargement. What about bifurcations? There are different approaches. First is a hybrid or blended approach, which means that the side branch is treated by DCB and the main branch is treated by a drug-eluting stent. I'm more in favor of the puristic approach, predilatation of main branch, side branch, then DCB side branch, and finally DCB in the main branch. Kissing is possible, but not necessary in the majority of cases. And then we have a very simple approach with smaller side branches. You treat only the main branch, and what we see is that after some time the side branch ostium gets better. This is an example from the old example from the PEPGAR-BIF trial here in the circumflex artery. Predilatation in both directions sequentially with carina shift and all this stuff, then using a DCB to the posterolateral branch, then to the main circumflex artery. And this is what you get. You have here some haziness. This means dissection. The lumen is not that perfect. But if you look here, 6 months later, the dissection has healed and the lumen has improved. And we looked at this patient with IVUS, and interestingly, the plaque volume was more than 50% less in the DCB-treated area compared to the areas which looked angiographically healthy. So that's also very interesting. Example of a trifurcation. So here, again, sequential treatment of all 3 arches with DCB. This is the result. Dissection here in this area, and more than 1 year later, the dissection has healed and the lumen has improved. And it makes your procedure much simpler. Imagine if you would do this with a stent-based approach in this trifurcation. Here, the data from the Korean group with respect to using the DCB in the main branch and not treating the side branch. And here you can see this lumen gain is seen in the main branch, but also in the ostium of the side branch. Very simple procedure for bifurcation. In real life, we are treating more and more complex patients with more than 1 lesion. And this analysis from Korea, again from Professor Shin's group, looked at 2 different treatment strategies in multivessel disease. Strategy number 1 was use DES for all lesions. Number 2, apply the DCB-only algorithm. And they ended with 2/3 of the lesions treated with DCB, 1/3 treated with drug-eluting stent. And this approach with less metal was, in this retrospective analysis, however, was associated with significant lower event rate at 2 years. This has to be confirmed in randomized trials, and those are underway or in planning. So, my conclusion for DCB multivessel and diffuse disease is that we have to deal with the stent-related event rate. The DCB-only strategy is to use to reduce the number and length of stents. Focus is on careful lesion preparation, which improves the outcomes of both devices. Device selection is depending on the lesion complexity, and the decision if you use DCB or stent is on a per lesion basis and according to the result of your lesion preparation. We learned from Max that intravascular imaging may be helpful in the future, but we have need a little bit more data to find its final role here. This procedure is safe because we identified lesions not suitable for DCB treatment that requires stenting, and we use dual antiplatelet therapy, which is also key for safety, and we have lateral enlargement, vasomotion, and no stent-related complications. Thank you very much.
So thank you very much, Bruno. We have 2 more presentations before we open up to discussion and your questions, and I can see lots of your questions coming in on the app, so please keep them coming and we'll get to them all at the end. You'll also be able to ask questions at the microphone. But first of all, Simon Eccleshall on real-world evidence on DCB.
Great, thank you very much. Thank you for the invitation, and thank you for being allowed to share essentially single centre data. And thank you to some colleagues in the audience that distinctly helped with all of the work. So I'm going to talk to you about essentially our centre's journey from stenting to DCB. So back in 2013, thanks to Bruno, as well as Franz Kleber and Klaus Bonaventura, I was invited into their labs, saw how they were working and came back home and decided that perhaps I didn't want to put stents in everybody and I should try doing some DCB work. So that was my initial conversion rate to around 50-50, and it then shifted up with more as I learnt more about lesion preparation, specialist balloons, etc. That was me over the next few years, so it's now something over 90% that I use my DCBs, a few percent for stents. By 2015, the rest of the department decided probably I wasn't mad and I should be allowed to stay, thank you, and that they were going to start using DCBs as well. So by 2015, as a department of 8 operators, we were DCBing and stenting at equivalent rates. We live in the UK, heavily regulated, which has its upsides and its downsides. So we are monitored on every single angioplasty that we do as operators, all of our numbers, and then as centres as well. And every year we choose to go to a meeting, and part of it is presenting the audit data. So this was 2015, so that's when we just converted. Everybody's been congratulated on putting lots of stents in, except us, because we were a little bit of an outlier by that time. So from 2015, those 3 years I just told you about, we were DCBing and stenting at equivalent rates. Although we're supposed to have yearly outcomes fed back to us from our national bodies, because it's the UK and it's the NHS, we ran out of money. So for those 3 years, there was a bit of a stop on data. And then all the data came out in one big rush for those 3 years, which obviously for us was quite important, but because by this time, everybody knew what we were doing. We were presenting what we could, hopefully showing we were safe, but we really needed to prove it. So what they look at is 30-day risk-adjusted mortality for operators and centres. So if you get a phone call because you're an outlier, then you have to start worrying. So this was our data for those 3 years. This is the rate that our patients should have been surviving. If we were doing a really good job, 2 standard deviations better would be there. I'm delighted to say that we're actually on this side of the screen. If I were the other side, I probably wouldn't be here presenting today. But essentially, we were over 2 standard deviations better. So more of our patients were surviving than would be predicted from the risk models that we were using. It might just be we're very good at selection. It might be that actually we're really good operators. Or it might be that we've only put stents in half of our patients. So we then started looking at some of the enormous database that we have, because we have to collect this data for our national body. One of the first things we looked at was driven by the fact that there were discussions around how long should you use dual antiplatelet therapy for drug-coated balloons. And at that time, the guidelines suggested 6 months. Most DCB operators are running at 1 month for elective cases. So we simply went into our database, found 300 patients that had only had dual antiplatelet therapy for 1 month, and looked to see at 6 months how many events they may have had related to stopping that dual antiplatelet therapy. And the answer was none. So one of the other concerns that people have is everybody goes back to the lab in the middle of the night. Well, that's wrong. The reason why people don't go back to the lab in the middle of the night is A, we are all now very aware and very good at doing angioplasty, whether it's balloons or stents, but we have the safety of dual antiplatelet therapy for at least a very short period of time. So we consecutively collected 100 patients that had elective angioplasty and were sent home the same day and showed that it was safe. We sent home 50% of them exactly with easily, obviously, visual dissections at angiography. So coming back to that data I was telling you about, we have data collected in a number of ways that we can then access in the future, and that builds into some of the work that I'm going to show you afterwards. One of the first things we were interested in was around this time, if you remember, was when suddenly paclitaxel was a really bad thing. All of our data, everything I'm showing you here, is with B. Braun's paclitaxel balloon. So suddenly everybody was very scared that for some reason that nobody could understand, very late in the day, people were dying if they used paclitaxel peripherally. We looked at all our elective work because obviously we could now track these patients. And one of the first publications that we came out with was this one. We looked for patients who'd never had an angioplasty before. So there's no confounding factor of somebody already has a stent in the other vessel. So they've no PCI before, no MI before, elective patients. We then propensity match them so it's as near to an RCT as you could get without being an RCT. We have 429 in each group, and I think the results are fairly self-explanatory in that DCBs do better, or the other way of looking at it is if you leave a stent in people long term, more of them die, and that was significant. So we then went on to look at different subgroups with more outcomes than just death. We have an elective cohort that's been published, again, big numbers as you can see, with no difference in all the usual endpoints. We then became a little bit more provocative. We looked at our left main stem group. We did propensity matching on these as well. There were no significant differences at all between any of the stented and not stented left main stems, DCB left mains. These are all unprotected. We weren't allowed to put the protected ones in for this particular publication. The all-cause mortality numerically was higher in the balloon group, and I think that reflects what usually happens in that we all tend to, in the frailer people, use DCBs, not stents. For all the other outcomes, cardiac mortality, target vessel, MI, and TLR, they were all numerically lower in the DCB group. We then became more provocative again, depending on how comfortable you're sitting now. We looked at our STEMI cohort, 450, 687, propensity matched. Again, no difference between the two groups. So what we're trying to do is use as little metal as possible. So as everybody keeps telling you, it's all about lesion preparation. For us, it was about relearning balloon angioplasty, and it's all about dissections, 3 parts. Avoiding them, that's good lesion preparation. Secondly, recognising the safe ones against the not safe ones. And thirdly, if you can, modifying the unsafe ones back to safe. So to get where I did with hardly ever stenting, I changed my approach to angioplasty, lower pressures, slower inflations, stepwise increase if necessary. Lots of scoring and cutting balloons. Calcium modification is still used, and I think Thomas is here, he's published on rotablation and DCB only. Physiology can certainly help guide, particularly in the very diffuse ones, which bit of that LAD to treat. Intravascular imaging can certainly help with deciding how to do your lesion prep, but I'd be careful about sizing and outcome measured by that. So where's this going? Well, I think PCI is changing. It's now all about lesion preparation. I'd like to just point out the definition of successful PCI is not putting a stent in. There are a number of destination therapies. Those are the main 3. So what do we think? To my mind, the least force and trauma that you can induce in that vessel while still getting a good result is where we need to be. And the least that you leave behind in the short and long term is the best. So I'd like to leave you with a new concept, minimal footprint angioplasty. I think in the future we'll be DCBing the majority, then some will have a scaffold, and then there's a new niche product out there called stents. Thanks very much.
Thanks very much, Simon. And now the final presentation before we open up to discussion is from Raban Jaeger, DCB and the challenge of calcified lesions.
Okay. Dear Chairman, ladies and gentlemen, thank you very much. My task today is to speak about calcified lesions. These are my conflicts of interest. I want to show you this slide, and I want to show you this nice young couple. They are sitting on a mountain in Switzerland. This is the Cru du Vent. This is a nice mountain range in the northwestern part of Switzerland, and you see really a lot of calcification there. This is the good part in calcification. However, these 2 guys, they are not interventional cardiologists, and that's why they're enjoying this view. However, an interventional cardiologist has a little bit more problems, because coronary calcifications are present in patients with a lot of comorbidities. The coronary artery disease is mostly more extensive, has longer and more tortuous lesions, and there's always a higher level of technical complexity with more difficult lesion preparation. And when you are using stents, you can damage them, damage the polymer during delivery. There's always some incomplete stent expansion and apposition, and taken together, this leads to a higher cardiovascular morbidity and mortality. What I show you here is not only based on my thoughts. We have seen that in lots of studies here. For example, a meta-analysis of BioFlow 2, 4, and 5. In these trials they tested our zero versus science. And what you see here is that in the red group with moderate and severe calcifications, the endpoints are always higher than in the non-calcified or mildly calcified lesions. This is true for stent thrombosis, for target lesion failure, for myocardial infarction, whatever. So stents are not always a good option, and especially in calcified lesions. So this is a DCB session. I just want to wrap up again the potential advantages and disadvantages. Advantages is this immediate and homogeneous drug release into the vessel wall. There are no implants, no permanent implants. There's no polymer, so you don't have device-related events. There's always a reduced depth duration possible, and there's a normal vasomotion. And in paclitaxel, there is this phenomenon of late positive remodeling. Disadvantages, of course, lesion preparation is more time-consuming. You need more devices. There are eventually more costs. And when you look at the result, it's not always stent-like. There are dissection and residual stenosis. And the biggest disadvantage of DCB therapy is the nocturnal fear of the interventionalist. I always hear, why you cannot leave this? I'm on call and you did the PCI and I have to stand up. As we heard, this is not an issue. This is just religion. You have seen this slide before. I want to point out the predilatation and options part in the middle. You have some options. You have specialty balloons, rotablation, and lithotripsy. And this is exactly what you have to do in calcified lesion as well. You have these three possibilities. In my view, you have this non-compliant scoring or cutting balloons for more the softer plaques, not so calcified plaques, and you have the intravascular lithotripsy or atherectomy devices. So you have even possibility to cut and crack, to modify your substrate, or to debulk. And this is what you can do in all lesions to get a good lesion preparation. When we just look at these possibilities, we have a couple of trials. These trials I show you now the next minute. These are trials where they did a lesion preparation and then unfortunately they implanted stents. But you see the results, what you can get if you use one or the other of these devices. Here in this Prepare Calc trial, they compared scoring cutting balloons versus rotablation. And in the red box, you see that rotablation is less cumbersome. You have no crossovers, and you have a high strategy success. The results after 9 months after implanting stents were similar. And here it is the RotaShock trial, again, randomized controlled trial. They used intravascular lithotripsy against rotablation, and they had a similar minimal stent area. They implanted stents in this trial in OCT. However, there was a little advantage for rotablation, but the results were quite similar. So you have different possibilities. Now, what about DCBs in this setting? There's not a lot of data. Thomas Risson, who sits there, has published this study here. He had 65 patients with calcified lesions and did a rotablation in all of these lesions. And you see that MACE rate was 14% after 1 year and 20% after 2 years, with a high rate of MACE in ACS patients. However, the TLR, target lesion revascularization rate, was really small after 2 years, and there were no acute vessel closures and bailout stent rate of only 10%. In another trial, this was not a randomized trial, this was a post hoc analysis. You see here they had 81 patients and they had calcified and non-calcified lesions. 57% calcified lesions, and in 82% they did a rotablation. What I saw is that in the follow-up angio after 6 months after DCB, they had positive remodeling here with non-calcified lesions and a really good result in calcified lesions. And the diameter stenosis was quite comparable, however, it was a difference, a statistically significant difference, but 17 versus 22%, which is not really not clinically significant, as shown here in the 2-year clinical follow-up. And another trial is this trial here. You see here that they had another retrospective cohort study, 135 patients in calcified lesions. They did rotablation in all the, or orbital atherectomy in all of these patients and randomized DCB versus DES. You see here the clinical results after 1 year. The two groups are quite comparable, and therefore, in my opinion, this is a safe procedure in calcified lesions. So I come to the end, ladies and gentlemen. You see the young couple again. Calcification has gone. They sit on the calcifications, they are pulverized, and they have a nice view to the ocean, the bright future. You could show a DCB there in the horizon, but I did not do that. And the take-home message is here, in my view, is that patients with coronary calcification, they represent a population at a high risk for cardiovascular events. You have technical limitations for DES with higher or increased event rates. And based on the mechanism of action, DCB may represent a good alternative treatment option for these patients. However, the calcifications, as they may inhibit drug transfer into the vessel wall, have to be treated. They may limit it, and so you have to do a good lesion preparation, either with rotablation or intravascular lithotripsy, and this might improve results. And the current data, they look promising, but larger studies with long-term follow-up needs to be awaited. Thank you very much.
So thanks very much to Raban, Simon, Bruno and Maximilian for sharing their experience and showing some interesting and sometimes provocative data. We have 12 minutes for questions, and there are very many questions coming in, and please, we can also take questions in the room in a moment. I'll ask everyone on the panel if you can please, to help get through these practical questions as quickly as possible, to keep your answers as brief as possible, and we'll try to cover them all in the next 12 minutes. So, Bruno, perhaps I'll hand over to you for the first 1 or 2 questions.
Yeah, good. We have several questions with respect to lesion preparation. One of the questions is, what is the sizing of your predilatation balloon, and how can we avert flow-limiting dissections, or can we convert flow-limiting dissections in benign dissections?
I start 1:1, the same size as the target vessel is, and with longer inflations, really long inflations, you can convert a type D or C dissection into the type A or B dissection if you are lucky.
And Simon, what about cutting scoring balloons? Is that an approach if you have a dissection?
Yeah, thank you. So it's one-to-one angiographically, that what you're talking? Yeah. So one-to-one angiographically, generally start with non-compliant. If there's then any problem, shift over to scoring usually. And from the point of view of modifying dissections, we're really talking about the ones that look really ugly with a lot of contrast in the wrong place. And I think with scoring or cutting, you're probably opening those dissections out into now non-flow limiting. Doesn't always work, but it will work in a proportion of cases.
Bruno, you might answer the next one because it's on bifurcation and you dealt with that. So, I mean, succinct tips and tricks. You told us what your preference was. There are a number of options, but practical tips and tricks.
One of the most asked questions about bifurcation is, can we do kissing DCB? The answer is don't do it because you have limited contact if you have two balloons besides each other, and the majority of the drug goes not to the vessel wall but distally. So this means use DCB always in a sequential manner when treating bifurcations.
Let's take a question here on the microphone, and we'll take some more from the app then.
All right, so the DCBs takes us back to the POBA days. Why we are not seeing as many abrupt vessel closures as we used to see back then? Is it more to do with the balloon technology or the technique in inflating those balloons?
Maximilian, would you like to take that one?
Yeah, actually, I do think that it's all about the decent, good one-to-one lesion preparation. I think we didn't follow the algorithm in the pre-stent era, like we have now, thanks to you. So I think it's all about that. I don't have much experience with, doing POBA before stents came. But I think we are just more cautious and we, put a high value and high emphasis to decent lesion preparation.
I mean, if you think about it, there are two things that are different. Number one is the balloon is coated with a medication. Does that have an acute effect? I don't know who thinks that it does. The second is the antiplatelet therapy, I suppose, has improved over the intervening 25 years. So, Simon, do you think does the coating of the balloon when you do this 60-second ablation, does that have some role in reducing abrupt vessel occlusion, or is that a stretch too far?
Yeah, a stretch too far, I think. I think the things that have made a difference is we're much better at angioplasty. We have much better imaging, whether it's angiographic or intravascular. We have a lot better tools at our disposal. But dual antiplatelet therapy is what changed the game from the point of view of going back in the middle of the night. Acute vessel closure rates now are really low. In our cohort, they are equally very low between balloons and stents.
I have a question about the practical usage of the DCBs. In my practice, if I used to use for hybrid situations for a side branch and the main vessel being stented. My question always comes in when you try to do the sequential ballooning, as you said, to apply the drug-eluting balloon to the side branch. You apply it and then you are never sure whether there has been a plaque shift, and then if you want to subsequently do a kissing balloon inflation, is that safe, or does it actually jeopardize the whole exercise with the side branch with the drug?
Well, you can do a kissing whenever you want afterwards with uncoated balloons, but the recommendation is not to use the DCB balloon in the first approach for a kissing procedure. So
subsequent kissing with non-compliant balloon, does it actually take away the drug coating from this vessel wall?
Not really.
I mean, it is something that comes up for discussion, isn't it? Simon, you maybe
depends on the product.
Okay. Yeah.
As in some drugs are in fast and stay there. Other drugs are still being delivered to the wall with the newer.
Because, I mean, there was conventional wisdom that you should try to finish with your drug-coated balloon angioplasty and then avoid further manipulation after that, which is this gentleman's question, I think.
Yeah.
Okay, I mean, we have 5 minutes. There's a lot of questions online. While you're preparing them, we'll take one more microphone question, yeah?
My question is that what's the incidence of restenosis after DCB for the novo lesion?
I mean, it depends which series you look at. Raban, would you like to take that one?
The vessel restenosis rate is quite comparable. But in the basket small 2 trial, we had the same rates for both groups. And the restenosis rates, they were similar, and but the follow-up is just 3 years. So eventually the story goes on for stents, but it levels out for DCBs.
And the minimal duration of antiplatelet?
The minimal duration of antiplatelet
for de novo DCB?
We used 4 weeks, but eventually you can go down to 1 week or even just a loading dose of aspirin or clopidogrel and then leave it. There's no data, but I think dual antiplatelet therapy is not an issue with DCB. Yeah. You can shorten it probably to the minimum.
I mean, it depends a little bit on the indication. So if it's acute coronary syndrome, I suppose conventional wisdom is we're treating the patient as well as the lesion. And there, I mean, we had new data at this meeting suggesting abbreviated DAPT, where the conventional approach had been ACS. Maybe don't shorten. CCS, you can shorten.
Thank you.
Excuse me, can I get last question?
1 second. We'll take one or two from the app, and then we'll come to you. We have time.
We have another technical question, and I think it's very important because we have sometimes acute elastic recoil. How long should we wait after the DCB treatment until we recheck? Do we have to wait 1 minute, 5 minutes, 10 minutes?
So if we get a great result, we move on very rapidly. But we've already, this is post-lesion preparation presumably, or post-DCB, it's the same, isn't it? We give people nitrates, we take a view or two, we have a chat about what a beautiful job we've done, and usually that's as good as it needs to be. If we're at all concerned, if it looks like there is some recoil, or there's a bit reduction in flow slightly briefly, we might wait another couple of minutes. But quite often it's literally one or two shots and we're done.
Okay, one more microphone question.
Thank you very much. Just a brief question about when should we wait for the result? I mean, like, when should we check and expect the result of the DCB? When the artery will heal, approximately?
Okay, so you're asking if you're going to do surveillance over time, when is a good time to have another look? Is it 3 months or is it 6 months? Not suggesting you do that systematically, but if you were going to.
Well, we never do a systematic follow-up of the patients because this is standard. DCB is standard in our center, and if the patient has a problem, he might come back. So we don't do it, but if you want to know whether you have a good result, I would say 3 months. Yep.
You don't want to look too early, because if you're looking too early for no good reason and you find a vessel that's still dissected, you then are in a bit of a dilemma as to what, if anything, you want to do. And generally the answer is just give it a little bit longer to heal. 3 months is probably the earliest you should look, and then 6 months, and everything that's going to heal is healed, and you'll have got all the late lumen gain.
Thank you.
Maybe we should have one question on CTO, because it is an interesting area. It would be good to hear other people's experiences. I know we've recently started in our CTOs, once we get the vessel open, to just do balloon angioplasty and then to leave the patients for a few months, recognizing that when we stent straight away and go back and check, you see the stents are often undersized. Even if you use intravascular imaging, the vessel gets bigger over time. So we've started to do balloon angioplasty and then call the patient back and see if further treatment is necessary. However, drug-coated balloon angioplasty in the acute phase might offer that as a definitive solution. Balloon angioplasty just in the initial index intervention. I mean, Maximilian showed nice cases. Do you guys have experience in your centres at CTO? Do you think it's a good idea or less supportive?
I liked the algorithm we had. Anything that you can wire antigradally, I think it is very fair game for DCB only. And we do exactly all the things you just said. You're allowed to call it an investment procedure, which means it doesn't count, I'm not sure. But you can certainly bring them back and you can deliver some drug the first time or the second time, or patch them up the second time when that lumen is twice the size.
Yes, please.
Yeah. Does the timing of the inflation matters or not? Because in some cases of ostial left circumflex, if you're occluding it, the left main, in case you want to do a drug-coated balloon. How long is usually recommended? 10 to 15 seconds of inflation. What is the usual recommendation?
I think the timing matters. I think it's normally better tolerated than you expect. If you have concerns, what I usually do is 30 seconds, wait, I leave the balloon inside you and do another 30 seconds. But I do try to do 60 seconds across the board.
I think the drug is delivered in less than 30 seconds, but you gain something if you have longer balloon inflations because you have a better primary side, and that's one of the reasons why this recommendation is longer is better. But if the patient is in hemodynamic unstable situation, you can also do 20 seconds. So that's for sure.
Just wait for a microphone.
Can I just ask, is it one balloon per lesion? Because you showed trifurcations being done. Does that mean you need to use 3 different balloons, or you can reuse your balloon for the branches?
Oh, no, you can't reuse a balloon.
Yep. So it's like 3 balloons per trifurcation.
It's a new balloon for every bit that you've touched.
Yeah.
Yep. And you don't need to use coring balloon if it's not calcified lesions. Is that right?
If you get a nice result with a non-compliant balloon the right size, then that's angiographically, then yeah, that's great.
Great.
Listen, we're going to have to close it there. We're over time, and the next session will be due in. I'm going to close the session by saying I hope you gained useful insights from the experts here on the panel, and thanks very much for all your questions.